Welcome to Just Awareness Day, Just Fireside Chat. For those who don't know, Just Awareness Day is on July 13th, and it's a time where just experts, patients, caregivers can come together to educate the public about this disease and advocate for finding a cure. During this seminar, all participants will be in a listen-only mode, and I just want to remind everybody that this webinar is not intended as a substitute for your physician's guidance and care. My name is Sarah Rothschild. I'm the Executive Director of the Life Raft Group, and I'm thrilled to introduce our panelists for today. Dr. Jason Sicklick will be coming shortly, but just to kick off, he's an internationally recognized surgical oncologist who specializes in treating GIST, abdominal retroperitoneal sarcomas, and liver tumors. He's the leader of the sarcoma disease team and co-leader of the structural and function genomics program at UC San Diego Health's Moores Cancer Center. He's also a member of the National Comprehensive Cancer Network Soft Tissue Sarcoma Committee and GIST Subcommittee, which develops best practices for treating these rare and often challenging to treat cancers. Dr. Andrew Blakely completed a Bachelor of Science in Biomedical Engineering, followed by medical school at Drexel University. He went on to general surgery residency at Brown University. And during residency, he spent 2 years of dedicated research time at the Center for Biomedical Engineering, developing a device for tissue engineering applications. Dr. Blakely then completed his fellowship in complex general surgical oncology at City of Hope National Medical Center. And Dr. Blakely is currently a surgical oncologist specializing in peritoneal surface malignancies and soft tissue sarcomas. One of the primary focuses of his research includes improving surgical treatment and ex vivo tumor modeling of GIST at the NIH. Unfortunately, Dr. Wiedekind had something come up last minute. You might have seen her in some of the original announcements, so she can no longer attend, and we are so grateful that Dr. John Glod is here to take her place. And Dr. Glod obtained his MD and PhD from the University of Colorado in Denver and trained in pediatrics and pediatric oncology at Cincinnati Children's Hospital, Johns Hopkins Hospital, and the Pediatric Oncology Branch of the NCI. Dr. Glod currently serves as the clinical director of the Pediatric Oncology Branch in the Center for Cancer Research at NCI, and his research interests are focused on early-stage clinical trials for pediatric patients and rare pediatric solid tumors, including multiple endocrine neoplasia-related medullary thyroid cancer, sdh-deficient GIST, and tumors of the central nervous system. So I would like to thank our patients and caregivers for submitting questions to us before the webinar. In case you missed it earlier, if you have additional questions or comments, you can type them in the chat features, and we can try to do our best to answer them during this live session. The panelists can chime in between answering their own questions. But if your questions don't get answered, we can also, if you just send us an email, we can work on addressing them afterwards, because we do have a lot of questions and we want to jump in. So let's see here. Let's see if my technology is working better. Somehow my window is not expanding. But I guess we're just going to get kicked off here. So at the beginning of a GIST journey, many times I think patients want to know, like, what's my prognosis or what's my risk of this recurring? So how do you explain risk to a patient, and what factors matter most in determining it? Who would like to start? I'm keeping this open.
I can start. So I think, when I think about risk, I guess that's referring to risk of recurrence, correct?
Yeah.
Yeah. So I think when we focus on localized disease, so the primary tumor in the stomach or the small intestine, for most GISTs, we're thinking about factors we can and can't control, is the way I kind of phrase it. And I say that there's 5 factors. 3 we can't control are tumor location, tumor size, and the mitotic rate. And of those, probably most prognostic is going to be mitotic rate. And those are things we can't change necessarily. The two things that we're in charge of, or we are in control of as surgeons, are the margins that we achieve in cutting out those primaries, and then the risk of rupture. So we want to really maintain that capsule or that pseudo capsule that is surrounding these gists, um, and avoid any spillage of tumor contents within the abdominal cavity. I think risk when it's outside of that primary situation is a bit different. And I think these risk criteria don't apply quite as or uniformly when looking at different subtypes. So I think one area of active research and interest is trying to say for KIT and PDGFRA mutant GIST, we're going to use kind of those traditional type criteria, but we might need different criteria for wild type, so to speak, SDH deficient, NF1 type GISTs. And that's an area that we clearly need more refinement, but I think that has come as we've understood these other subtypes much better.
Okay, great. And for Dr. Glad, for younger patients or those newly diagnosed with SDH deficient GIST, is the approach to follow up different? Like, how would you frame that question? And I know sometimes if they're diagnosed, in earlier years, there might be just many more years of follow up and just questions about what are the risks of repeated scans or just lifetime risk of radiation.
Yep. Thanks, Sarah. Thanks for inviting me. And Dr. Wedekind sends her regrets. She was called away at the last minute, unfortunately. So yeah, I think the pediatric GIST or SDH deficient GIST is kind of a different paradigm than KIT and PDGFR alpha driven GIST. And for PDGFR alpha and KIT driven GIST, I'm speaking a little bit out of turn because I mostly see kids. There's a number of different drugs that can be effective, and the prognostic features that Dr. Blakely mentioned at the beginning, the size, the mitotic index, are well correlated with prognosis and whether a person needs adjuvant imatinib. In SDH deficient GIST, we, as best we can tell, those prognostic features that are apropos to KIT-driven GIST don't apply. So often patients will look and their SDH deficient GIST will have a higher mitotic index, but we don't think that makes a difference. And usually when I talk to people with SDH deficient GIST, particularly kids, I kind of put it in the framework of, you may have known other people with different kind of cancers, and the sort of standard paradigm that people think of with a cancer is you get the cancer, you get some kind of treatment, and then you're, either you're cured or you're not. But it's different with SDH deficient GIST. The timeline is generally much longer, so it's a very slow growing indolent tumor, even if there's metastatic disease somewhere. People often are okay or do well for years. And the other caveat is that it's due to a mutation or a change in the DNA that are present in a number of different cells in the body. And so you might get another GIST at some point in the future. And so it's almost like a chronic disease. It's indolent. It's unlikely to cause someone to die in the immediate future, but it's something that we have to follow, and it's something that we have a number of different potential treatments that might be used over time. So it's kind of a different thought process. It's a longer period of time, a longer timeline.
Okay, great. I kind of want to move on to surgical considerations. So I'll start with Dr. Blakely. How do you decide if surgery is the right choice, especially in metastatic GIST?
Yeah, I think there's two components. One of them is, what is the behavior of the tumors coming into a planned surgery? Generally we would prefer not to operate when the tumors are growing rapidly, especially in multiple areas over time. We don't have that sort of systemic control. And of course, that systemic control is going to be dependent on the subtype, since some drugs are going to work for some types of GIST and not for others. But if there's an opportunity to achieve that sort of global control going into surgery, it makes us feel better about the outcomes of the surgery and the risk of short-term recurrence of disease. And then the rest of it is a largely sort of technical consideration as far as what structures are around the gist? What do we have to take into account as far as the planned operation? I don't know that there's such a thing as too big or too many, but my threshold is going to be different from other folks. Dr. Sicklick's threshold is going to be different from other folks as well. And so, I think it's everyone should have not just one, but probably at least two surgical opinions in general. Some of the things that we can generally rely on in GIST that we don't have in other diseases that we operate on is that pseudocapsule around it tends to push structures aside as opposed to invade them. Sometimes they can get a little stuck onto certain areas. But these sort of debulking or cytoreductive surgeries, I think, are in some ways easier than they would be in other things like a colon cancer or something like that. So, I think it is a matter of having, good imaging and, a detailed assessment of what things look like, and then understanding if the patient would be able to tolerate that sort of intervention as well, depending on what's going to be involved.
That was really helpful. And I know, Dr. Glad, you're not a surgeon, but when you're as an oncologist, speaking to patients, at what point do you, consider if surgery is often delayed or approached differently, thinking about systemic therapy firsthand?
I think, I think when you're thinking about any sort of medical decision, I think the things you want to consider are why are you doing it? What might be improved by this course of action? And then what are the potential risks and benefits of that course of action, and what are alternatives? And so I think it's useful to kind of go through those steps each time. Why are you doing this particular intervention, whether it's medical or surgical? What else would be a potential choice? And one choice could be not doing any intervention at that particular time. And so I like to try to think of all of those things. I rely on Dr. Blakely and Dr. Sicklick to tell me what are the risks and what are the chances of achieving the outcome that we're looking at, whether it be resolution of pain, whether it be putting off of side effects like bowel obstruction or something else like that, and what are the side effects, of a partial gastrectomy or whatever else the surgery might be, and then talking through with the patient those considerations. And it's different for different patients, so different side effects might be impact a person's life differently depending upon who they are. And I think we have to kind of work together as a team to figure out what are the risks, what are the benefits, and what's the best course of action for that particular person.
Great. And I know that multidisciplinary team is also really important in factoring all those decisions. Um, Also, just maybe Dr. Glad, I hear a lot of people hear mutation, they feel overwhelmed. Can you help us understand, how and why does a GIST mutation happen in the first place? And maybe you could speak also to the pediatric or the non-KIT PDGFRA cases as well. How does that impact treatment decisions?
Yep. Thanks, sir. And I see Dr. Sicklick hopped on here too. So, um, yeah, that's a great question. We would all love to know why mutations occur initially in a GIST, whether it's a germline mutation leading to an sdh-deficient GIST or an NF1 mutant GIST, or whether it's a KIT or PDGFR alpha or BRAF or NTRK mutant GIST. And I think the real answer is we don't really understand why that happens. I think trying to look at the different types of mutations, like the mutations that occur only in the tumor, like KIT and PDGFR alpha, that are nowhere else in the body, and how they're different from having a germline mutation where the mutation could potentially be passed on to offspring and could lead to other tumors over time, is important. And I think one of the, if you've gotten foundation medicine or any of the other mutation testing, you get a big long like a 10 or 12-page report. It has a lot of stuff in there. I would encourage you to sit down with your doctor and kind of go through it piece by piece, because it's actually not as complicated as they make it seem. There's a giant list at the end of all the genes they look through, and there's other things about what they're looking at, and there might be a number of variants of unknown significance that we really don't know what they mean. And so I think it's important really to sit down with a genetic counselor or your doctor and kind of go through it so they can really explain to you, this is a mutation we know is important and we know this is what it means. And these are other things that we really don't know. So I don't know if that answers your question, but yes, those reports can be intimidating to many of us. And I think it's important to sit down and really go through them and make sure you understand what is important in the report and what sort of really information we could take from them.
And some people want to know, like, yes, you can start asking questions in between, and we'll see what we can do to address it in the chat in between things in case people are wondering. But Dr. Blakely, are we at the point where all patients should get molecular testing right away?
I think it's easy to advocate for. I think that by and large, my answer would probably be yes, unless it is something that is so low risk that it wouldn't influence management. So if somebody has a 1.8 centimeter gist taken out of the stomach with a reasonable mitotic rate, that's somebody who's probably going to have a very low risk of recurrence. So you probably wouldn't need testing, molecular testing of that tumor. I think anything where there might be a consideration for therapy, either before surgery or after surgery, and certainly if there is anything in family history or personal history that would suggest that there's something more than just a, quote unquote, conventional type gist, then I think it's important. But I think the other thing is, sometimes we've taken out a 3 or 4 centimeter gist and everything comes out well, but then we find out after the fact that there's a PDGFRA 842V mutation in the gist, and that's important then, because if the patient has a recurrence, at least then they know that they probably don't need to spend time on imatinib, which is unlikely to do anything beneficially for the patient. So whether beforehand or afterhand, I think if there's any chance it's going to influence treatment, I would advocate for it as much as possible.
Somebody
Yep,
just wrote in. Oh yeah, go on.
I agree, and I would add that for any pediatric patient that has a gist, I would get testing on all the pediatric patients.
Yeah. Somebody just wrote in, it has like, knowing the mutations change the standard of care. I don't know if you've spotted that, but anybody want to address that?
Yeah, I mean, I think it's, if I guess first, sorry, I was a little bit late.
Welcome, Dr. Sicklick.
Sorry, I was in the operating room.
Yeah.
Yeah, it actually has. I mean, we're just as set the precedent for using the molecular testing as a method for selecting drugs. We know that with the KIT mutant gist that they respond to imatinib, for instance, but we've gotten more nuanced over time where we can say, for instance, a KIT exon 11 mutant gist will respond to 400 milligrams of imatinib versus for a KIT exon 9 mutant, we might talk about giving 800 milligrams of imatinib, where it's actually not only the gene that's mutated, but actually the part of the gene that's mutated actually starts dictating the drugs. As was sort of alluded to by Dr. Blakely and Dr. Glod, being a PDGFR alpha mutation, we can start understanding if they've got the D842V mutation, those are going to be resistant to imatinib, but they'll be sensitive to one of the newer drugs, avapritinib. That being said, sometimes there are other PDGFR alpha mutations that are sensitive to imatinib, and so I think it's really important that we start including that as the sequencing. We know, on the hereditary side, that the NF1 mutant GIST don't respond to imatinib. So anybody with that has no neurofibromatosis, or if they've identified have a mutation in the NF1 gene, even without having neurofibromatosis, the syndrome, which is the inherited syndrome that goes from parent to child, those individuals are not going to have tumors that respond to therapy. And so it's really becoming increasingly important to utilize this data as we go forward. We're getting more sophisticated too on the metastatic setting as time is going on. Now we're starting to realize that we're sort of there's trials going on right now looking at sunitinib versus ripretinib. Sunitinib, the FDA approved in the second line versus ripretinib in the fourth line, but trying to really tailor therapy where patients with a KIT exon 13 mutation actually don't respond very well to ripretinib, but they respond to sunitinib. And vice versa, those patients with a KIT exon 17 mutation don't respond as well to sunitinib as compared to ripretinib. And so, we're getting more and more nuanced as time goes on, and that's where this molecular testing is becoming increasingly important in our decision making, whether it be preoperatively, if somebody's getting therapy before surgery, postoperatively, if there's a discussion of giving adjuvant or postoperative therapy, and then certainly in the metastatic setting as well. We don't want to administer a drug that has no potential for benefit, but all potential for side effects or toxicity.
Yeah. Speaking of molecular testing, are there any new or non-invasive ways to test for mutations like blood tests? Because there's like a growing buzz about its potential. We wanted to know where it stands now. There were a number of people who submitted questions about this before the webinar.
It's something that's evolving. Certainly, what we know is from what's been published and what all of our experience is that in patients with small tumors, with localized tumors, with very low volume of disease, they tend not to shed DNA from the tumors into the blood. And that's where the blood testing can be done, or known as circulating tumor DNA, where it's basically DNA being shed by the tumor cells. When patients develop disease that's more extensive or have very large tumors, and when I mean large, sort of, over 15 centimeters, there's a higher likelihood of those patients having it in the blood. Now, still, from you look at the published data, it's only, part of it is probably an issue of detection and just the sensitivity of the tests that are out now. But in people with metastatic disease and with very large tumors, still only about a third of patients have detectable circulating tumor DNA. It's probably getting better as time is going on, as the tests are becoming more sensitive and picking it up, and just the technology is evolving. But we're still not, still not 100% where you could just follow somebody purely based upon their blood. It is helpful in the sense of if it is present, it can help you with decision making, perhaps. If it's absent, it doesn't give you any prognostic. It's not going to say like you're going to do better or you're going to do worse. It just says that data is not available for us to utilize in our decision making.
Okay. I want to turn to, speaking of decision making, and when it comes to choosing and sequencing treatments, Dr. Sicklick, how do you decide which drug to start with or when to switch?
So, I mean, generally, if somebody has a KIT mutant GIST that's KIT exon 11, generally we'll, start with imatinib. On the other hand, if let's say we sequence somebody and they are found to have an NTRK fusion, well, we know that those tumors will respond very well to an NTRK inhibitor. And so it's really a matter of using, as a starting point, using that data that is obtained from the genetic testing to then help guide the management. Certainly, as Dr. Glod was speaking about before, the sdh-deficient GIST, some of the drugs that we use for the KIT mutant ones don't work for the sdh-deficient GIST. And so it's really important not only to find the right drug to give, but also making sure we don't give the wrong drug to that patient as well. In terms of switching, generally, we generally recommend switching therapies when that given therapy is no longer effective, meaning somebody's tumors are growing or progressing in the presence of being on that therapy, or if they've developed some type of side effect or toxicity that precludes them from being able to tolerate that drug.
Okay. And then just looking ahead, are there promising treatments or trial strategies coming that could change how we treat GIST in the next 1 to 2 years?
I think there are. There's many trials that are open. On especially on the KIT mutant side. So I sort of was alluding to before, there's trials of the sunitinib versus the ripretinib, where trying to decide if somebody has a mutation in exon 13 and 14 versus 17 and 18, what's the right drug for them, where we can, where certain, now where we would say, okay, ripretinib is the 4th line FDA approved agent. Well, it might actually bring it up to 2nd line if this trial is positive. There's other trials that are ongoing. There's a trial of imatinib plus a drug called ziftomenib, which is an inhibitor that sort of turns off expression of the KIT gene, which in combination with imatinib, the hypothesis is that would basically kill these cells that are so dependent upon KIT, even if they have a KIT exon 13, 14, 17, 18 mutation that might be resistant to imatinib because you're just turning off the lights, if you will. And so it doesn't matter if it's a red light, green light, blue light, the lights are off, then it doesn't matter. And so that trial is ongoing. There's trials of an antibody drug conjugate, where it's basically an antibody that targets KIT connected to a drug that then enters the cell and kills cells. There's drugs like there's trials of like IDRX42, which is a broader KIT inhibitor. So we're now sort of moving towards studies of these broad KIT inhibition, where you're trying to hit as many of these different types of KIT mutations. And so IDRX is one drug. There's another drug that's actually a combination trial of sunitinib, which is the FDA approved 2nd line drug, with bezuclastinib, which is another drug that basically is a KIT inhibitor that has broader KIT inhibition. So trying to combine these together, where you're basically trying to wipe out every single KIT mutation, if you will, through these combinations of drugs. And so there's a lot of different strategies that are being studied in order to try to overcome not only the issue of drug resistance, but also the issue of persistence, meaning that sometimes people will not develop a new mutation, but just the drugs stop working very well. So imatinib might kill half the cells, but half the cells just sort of hang out and sort of talk about them being persistent or quiescent, where they're just hanging out. They're not dying, but they're also not dividing, but they're just kind of waiting. But as soon as that drug is stopped, for instance, those tumor cells might start growing again. And so there's different ways that we need to be thinking about it in terms of strategies to try to overcome these different issues that we find with the tumors.
Okay. And if we're talking about like a subject that you think a question pops in that's relevant, feel free to pop in and address them. But I think I just saw, at what point do SDH deficient GIST patients treatment before surgery? I think people are interested, Dr. Glod, in terms of what gives hope in terms of targeted options for SDH deficient GIST patients, if there's trials or what current therapies there are to try for that population. Can you address that?
Yeah, sure. I can answer that. I think I can try to answer that question that's popped in the chat. So, I think most of the time we don't do medical therapy prior to surgery in SDH deficient GIST patients. And another thing I think we like to know before we do a medical therapy for a person with SDH deficient GIST is what is the growth rate of their tumor. So at the time of diagnosis, even if a person has metastatic disease, something in the liver, in addition to a primary tumor in the stomach, if the tumor is not growing very rapidly, sometimes we can go for some time without thinking about systemic therapy. So I think upfront, it's surgery to try to prevent whatever symptoms brought that person medical attention. Usually it's bleeding or pain. And then potentially, depending upon what Dr. Blakely and Dr. Sicklick think, we can address metastatic lesions at that same time during that same surgery. And then usually we like to wait and see what sort of growth rate the tumor has, because many times it won't grow very much and you don't need medical therapy right after that initial surgery. So hopefully that answers that question. There are a number of trials that are plan for SDH deficient GIST. One is Dr. Sicklick's study of temozolomide plus something called a death receptor 5 agonist. It's a drug made by a company called Inhibrx. I think that study maybe will be up and going in the next year. There was a very nice study of rogoratinib, which is an FGFR inhibitor that Dr. George ran, and I think there is some interest in trying to identify another FGFR inhibitor because there were some results that were promising in that study. And then I think there's also the anti-KIT antibody drug conjugate that Dr. Sicklick mentioned. So all GISTs will have the protein of KIT on their surface, even if it's not mutated, like it's not mutated in SDH deficient GIST, but still that drug could potentially be an option for SDH deficient GIST. And there's another drug called overembatinib, sorry. I always have trouble saying that one. That had some very promising results in trials in China, and I think there's some interest in potentially developing a trial of that drug here in the US. And then finally, there are some discussion of another combination of temozolomide with a drug called a PARP inhibitor, which is a drug that blocks the repair of DNA, and that potential for a trial is kind of in discussion, I think, at some point. So as opposed to 15 years ago when we had no potential useful drugs and for SDH deficient GIST, I think really there's a lot of potentially really good avenues to explore that might be useful for different types of SDH deficient GIST. So I think there's a lot on the horizon that's very promising.
Exciting. That's very exciting.
I'm sorry, I lost my Wi-Fi connection as he was starting to talk. So
Dr. Glod did, he did well.
He hit it all. Awesome.
Yeah. I want to move to how we can help. Like, research is really important. I know for all of us, we want to find a cure. We want to aim high and see what we can do for all different subtypes of GIST. So really often we ask, how can we help? What can we do to move the science forward? So I want to ask you first, Dr. Sicklick, you've been deeply involved in patient-centered research. What can we do to help you move your vitally important research forward?
That's a great question, and thanks for bringing this up. It's really important, especially in this time, with funding and budget cuts, that advocacy with Life Raft is crucial. Patients and Life Raft and family members all sort of advocating for funding to study these this disease or these diseases is critical. We're obviously in an era where there's been budget cuts, both in the NIH, and Dr. Glod and Dr. Blakely can speak to that, but also externally, for doing research outside of the NIH. But it's also sort of trickling down to also industry funding of trials, just because of the uncertainty of the economy right now. And so, obviously, not only advocating for continuing to fund the research and advocating that the importance of doing this because of the potential for identifying better treatments and ideally cures, but also fundraising is also a crucial part of this as well, in order to support the research for individuals, labs that are studying GIST as well.
Okay, very good. So I think that that's very important for the community to know that, because of all these uncertainties out there, that we have to really do our part to help the community with fundraising and supporting research, volunteering for trials. There's a whole, span of things that we can do. I'd like to hear. Yeah.
Sorry, the one other thing I would add that's also really important is sharing tissue when one of yourself or your family or somebody else that is having an operation, because it's through having access to tissue that we can do research, that we can develop new cell lines or do mouse models or do all different types of experiments on, in trying to figure out what is a better therapy, or how do we better prognosticate for patients so that we can have a better understanding of whose disease is more indolent and whose disease is more aggressive. Without without the patients being involved, we won't make progress. We can't make progress.
That's very important. I'm glad you mentioned that, because we did launch, actually everybody on this call, along with the Life Raft Group, we've launched an SDH biobank. So it's absolutely crucial if somebody is an SDH deficient patient, they're going to be having surgery, to please contact us. We can help facilitate that tissue transfer for exactly the reason that Dr. Sicklick mentioned, or go to these renowned surgeons on the call directly for surgery and having that tissue stored and done research. But also, like, the Life Raft Group does have a paraffin-based tissue bank. So even if you've already had surgery, still be in touch with us. I think there's still ways that you can help contribute your tissue, your information, your time, to help really make a difference in this field. I do want to ask Dr. Blakely about how can patients, families best partner, besides what we said with tissue, if you can think of any other ideas about how we can partner with researchers to get involved in your research.
Yeah, that's a great question. I would say, a lot of patients come our way because of family when they're trying to find treatment options for their family member who's affected by GIST, and of course the Life Raft Group. And I think that the engagement is really important, and I think that a lot of patients have benefited from those connections, and also just talking with other people who have gone through perhaps similar, perhaps slightly different experiences. And I think it is very much partnership. And, we kind of think of it as like the triangle where we have the providers, we have the patient, and we have their support group. And we all have to work together. And when that is in place, I think the outcomes are the best they can possibly be.
Thank you. Well said. Dr. Glod, do you want to add anything there, or anything else about how families
I just want to reiterate everything that people have already said, and what a critical role that not only in providing tissue, but even I can remember, not at the very beginning of the GIST clinic because I wasn't here, but at the almost beginning of the GIST clinic, just the role that patient advocates play in bringing attention to the disease. There's both from a policy standpoint and a scientific investigation standpoint, but just making sure people understand that. And if you talk to a policymaker about an esoteric type of disease that's fairly rare, that's not connected to a human story, it doesn't really make much of an impact. But talking about how a disease affects people really can help to bring it to the forefront and spur investment in research and policy.
Excellent. I know that there was a number of questions that came in. We want to have some time to address them. I'm going to have Rebecca show her screen. She works closely with me at the Life Raft Group, and she can help field some questions to you guys and partner with me on hosting. So go ahead, Rebecca.
Hi, all. Thank you for joining. The first question I see Dr. Blakely would like to answer: does mitotic rate change when you have a reoccurrence, or does it stay the same as the original tumor?
Sure. So I think the mitotic rate is a little bit of a static assessment overall. I think when we look at change over time, we're probably looking more at treatment effect under the microscope with the pathologists. The mitotic rate can be different if we're looking at 5 different spots of GIST. It's probably not going to be the exact same thing in all of them. I think when we think about prognosis, we tend to use the mitotic rate from the primary tumor to say risk of recurrence when it's localized disease. How to use mitotic rate in other situations is a little bit, I think, still up in the air, but it does give a sense of the relative aggressiveness, or what we call tumor biology. And I think that still generally holds true for the KIT or PDGFRA mutant GIST. So, finding metastases with a mitotic rate of 2 is going to be different as far as expectations and counseling versus 20.
Thank you, Dr. Blakely. The next question is from a newly diagnosed patient. She's had 2 CT scans. She's read about PET, but both MDs she's dealing with says, I don't use that. The research indicates it's good for a baseline. She doesn't have mitotic rates. It's FNA isn't big enough. Does that make PET more important for me, or is it not important?
I mean, personally, I honestly don't use it very often either. I don't find that it adds much more beyond the CT scan. In most situations, where I think PET comes in handy is often when there's sort of a diagnostic dilemma, or where there's sort of uncertainty about something, or somebody may have a history of another cancer, and we're trying to figure out, trying to understand what's going on. But the lowest level of detection of a PET is generally about a tumor that's a centimeter or greater, and honestly, like a lot of times those are often visible on just a regular CT scan as well. So the PET scan doesn't often, add a lot for when things are fairly straightforward. If things are getting complicated or confusing, or one thing's growing and one thing's shrinking, or something on a CT scan was one area is brighter than other areas, or we talk about enhancement from the IV contrast, and we're trying to understand, is there sort of different clones probably evolving, or some different biology that's evolving that's making the tumor more heterogeneous or kind of variable throughout? That's where we might think about using it more.
Thank you. Do we know, are we getting closer to understanding why 1 in 4 patients with sdh-deficient GIST experience aggressive disease while the others do not?
We're studying that in my lab right now. We're trying to, we don't know why certain patients with sdh-GIST have more aggressive biology. We're investigating that in the lab, just as both using some of our cell line models through tissue that we've obtained through the SDH biobank, as well as doing analyses using different molecular techniques where we're trying to figure this out. But I think we're still not, at a point where we can definitively say, one direction or another, but we're moving in that area so that we can try to understand this better.
Thank you. I'm trying to read through to address as many as possible. This is another SDH question. Since SDH-deficient GIST comes from a change or variation in the DNA, does that mean there's always a big chance it can grow again?
Yeah, that's a good question. Probably not. We know there are some people that have the germline change in the DNA that predisposes you or gives you a higher risk of SDH-deficient GIST, and some people never get a GIST. So, I think people with the germline SDH mutation are at risk of getting a second GIST or a paraganglioma, but I don't think necessarily that that risk is 100%.
One of the things that we're working on between NIH, Life Raft, my group, as well as in collaborations with groups in Europe, is we've actually pulled together almost 400 patients to try to understand sort of the natural history of the SDH deficient GIST. And so it's really an example of a collaboration amongst all of us, both on the patient advocacy side and the physician side, to try to utilize the data that's collected through the NIH clinic, through our individual institutions, and through the Life Raft registry, in order to continue to wade through and trying to understand this and trying to learn more about why, perhaps why certain people do develop, new tumors and other ones don't. And, so there's a lot of unanswered questions, but it's through sharing your data through sharing your experiences that we're all learning, in real time.
All right. Thank you, Dr. Sicklick. Sarah, I got a text that you're back. Everything's going well, but let me do one more question. I'll pass it back to you. I found one from the chat. For someone who has been informed they have stage 4 non-operable GIST, is there ever a time where surgery may be decided upon? Meaning take out tumors from liver, knowing that they had many more in there. Not sure. Just wondering if partial removal has different outcomes.
Yeah, I think that the term inoperable or unresectable needs to be validated by at least 2 surgeons, and ideally 2 surgeons who are familiar with GIST. So, me, Dr. Sicklick, and there's other folks around the country. For example, everybody's threshold is a little bit different. I would say that in general, partial removal may make sense, but a lot of times we try to do as much as we can at the time of an operation. But whether it's the liver or the omentum, we can do fairly extensive surgeries depending on what's going on. So I would say that really you want to have at least a second, if not a third opinion before accepting not being operable. And that's also a dynamic sort of situation where in one sense it may be inoperable, but then with effective treatment that may change.
But and that, adding to that, what I would say is that sometimes we will resect tumors even if we can't take all of the tumors out for a reason, like somebody's bleeding and we can't, we need to sort of palliate a problem, a symptom, they're obstructed from it, or they're having significant pain from a given tumor, where we may operate knowing that we can't remove every tumor. But that being said, it doesn't make sense if, to just go in and say, okay, we're going to take out these 3 and, leave these other ones. I would sort of equate it to, if you're going in your garden, you're taking out all the weeds, it doesn't make sense to, take out half the weeds and leave half the weeds there, right? Because you're still going to have weeds in the garden. If your goal is to clear the garden of the weeds. So just doing it for the sake of taking a couple, trying to get rid of the number of tumors is probably not very beneficial, just for the sake of just trying to decrease the numbers. It's really a matter of, no situations for symptoms or things along those lines. Now, that being said, there's been trials that have been attempted to accrue patients to try to compare whether there's a role for cytoreduction or taking out all the tumors in patients with GIST. And unfortunately, just the trials that were done in the United States never enrolled, and there was one done in China that was closed early due to lack of accrual. And so there's still debate within the surgical community of what is the role of cytoreduction or these surgical debulkings. Patients in Europe often, or surgeons in Europe will often, in the absence of a randomized clinical trial, which is sort of the gold standard way that we prove the benefit or lack of benefit from something, won't necessarily offer this approach. So again, as Dr. Blakely is saying, it's also get other opinions, because data is up for interpretation, and so you might get different opinions, looking at the same thing from different perspectives.
Thank you, Dr. Sicklick. Let's try to take 2 more questions. If the patient has been on imatinib for 6 to 12 months prior to surgery in order to shrink the tumor, it is my understanding that it is difficult to get accurate mitotic rate or biology of tumor. So why go on imatinib pre-surgery?
That is true. We will often recommend giving imatinib prior to surgery for several reasons. One is in challenging locations, sometimes if we can get the tumor to shrink down, and we can make the operation safer or easier. Challenging locations often being things like right where the esophagus becomes the stomach, or the gastroesophageal junction. Sometimes in the duodenum, which is the first portion of the small intestine, if we can get these to shrink down, it might be able to allow us just to remove the tumor and not have to do a sort of a larger operation called a Whipple procedure or a pancreatic duodenectomy. Down in the rectum, we can sometimes use it because rectal GIST can often be large, and you can get those to shrink down. It might be able to save somebody from having a rectal resection. And so the benefit there is trying to sort of do a smaller operation, potentially a safer operation, shrinking it down, maybe be able to save adjacent organs that may be, being invaded or getting significantly pushed where you can't separate the tumor from the adjacent organs like the spleen or the pancreas or the colon. And so there's technical aspects to it, but it's also there's biologic aspects as well.
Thank you. Somebody did write in, and I do want to address it. Is there any news about immunotherapy and GIST?
So I think we're still learning. I think that there's been a couple of trials that have been run. There was one at Arun Singh ran at UCLA, where they did a combination of 2 different immunotherapy drugs that targeted different immunotherapy targets. There was one responder out of, I think it was 12, 13, or 14 patients. I can't remember exactly how many the denominator was, but it was one responder. So so somewhere in the 8, 9, 10% response range somewhere. There was a second trial that was run as a combination of an immunotherapy with the dasatinib, and that trial was closed early due to non-responders. There was a third trial that was just reported about a month or 2 ago from Europe by Dr. Rutkowski in Poland and his group, where they did axitinib, which is a tyrosine kinase inhibitor, with an immunotherapy, and the response rate was about 9% as well. So basically, I think the takeaway is, fewer than 10% generally of patients are responding. So it's not a hit it out of the park right now, but perhaps as we learn more about the immune system, and there's other drugs that are developed to target other parts of the immune system, because these drugs that we do have don't all target the same thing in the immune system. And so different ways of revving up the immune system that we haven't explored yet, maybe still future options that remain to be determined.
Thank you. I do want to make note that there are over 100 questions submitted, and we have been trying our best to address them all, that between pre-registration, the chat, the Q&A. If you have a question that has not been answered yet, please email us at liferaft@liferaftgroup.org. I could put it in the chat. We have a dedicated team here, and we're here to support you. So I just want to make note of that. And with that, I'll pass it back to Sarah. Are you good to go?
Yeah, all good. Thank you so much. So I would like to, before we wrap up, ask each one of you, what gives you hope right now in the world, GIST? Dr. Blakely, want to start?
Yeah, I think for me, it's there's a lot of clinical trials out there now, and they are becoming more subtype specific, which I think is better to try and refine our treatment approaches and help tailor treatment specifically to the types of GIST that patients have. And I think that for surgeons, that also helps us, because then, we can expand eligibility in a lot of ways, because if we have effective systemic treatments, we can open up surgery and other treatment modalities that may otherwise not have been on the table. So I think that our roles are continuing to expand as these treatments improve, which is just an exciting time, as opposed to 15, 20 years ago, where we just didn't have the breadth and depth of treatment approaches as today.
Thanks, Dr. Glod.
Yeah, I just think back to how, now at some of the meetings, when there's a meeting for people interested in GIST, they don't all fit at the table, like they did 15 years ago. And I think just the increasing interest, the number of available trials, I can't remember a time when I could give patients several different potential trial options, as opposed to say, oh, I don't know, there might be one that's a possibility. And as Andrew said, just parsing down, I mean, imatinib was a giant breakthrough, but now there's so much more information about who should be treated, when they should be treated, how long they should be treated, what's the specific dose of imatinib they need. I mean, the field of GIST has just become so much more and nuanced. I think Dr. Sicklick used that term, than it ever was before, and the progress has really been kind of amazing.
Great. Dr. Sicklick?
Yeah, I mean, it's hard to add on much more beyond those answers, but and I think we're the rate at which the discoveries are being made now is just exponentially increasing, and so it's giving us a lot of opportunities for new therapies, and as we understand more about the biology, and as there's more drugs available for other diseases that can maybe be repurposed for GIST, brings in other opportunities that perhaps we haven't even thought about. And so there's a lot of new areas for still that remain as unanswered questions that we are still challenged with. But as we make progress, obviously overcoming one hurdle then opens up another set of hurdles that we then have to figure out. And so but hopefully as time goes on, we'll be able to get beyond all these and eventually have a cure.
Sure. Yeah. Well, thank you so much, not only for your time, but your passion and just the clarity and the deep commitment you have to this community. And we also want to thank the patients and families who've submitted questions and continue to push this field forward as well. Just want to remind everybody that we hope you celebrate GIST Awareness Day on Sunday, knowing that there's a huge community that supports you. We do have a question for the audience. If you can and maybe you can put this on the Kudo board link that Rebecca put into the chat. What is the one thing GIST has taught you about yourself, life, or people? So I'll leave that for now and really reflect on that and go to that link and post that so that we can engage the community. And I just want to thank everybody for your time today and shedding awareness, and for our speakers who've also participated and who are such great partners at the Life Raft Group. So have a wonderful weekend, everybody. Take care.
Thanks, everyone.
Thank you
Very much.
Take care. Bye.